Hello friends, I'm Dr. Jiyut Ram. Today I will discuss about hypertension and its treatment. Hypertension, high blood pressure is a trait as opposed to a specific disease, represents a quantitative rather than a qualitative deviation from the normal level of blood pressure at which the benefits of treatment outweigh the costs and hazards. Hypertension is a condition in which arterial blood pressure is chronically elevated. Hypertension and its risk, leading causes of the global burden of disease. Approximately 7.6 million deaths, 13 to 15% of the total, and 92 million disability adjusted life years worldwide. 2001 doubles the risk of cardiovascular diseases, often is associated with additional cardiovascular disease risk factors. Antihypertensive therapy clearly reduces the risks of cardiovascular and renal disease, but large segments of the hypertensive population are either untreated or inadequately treated. Etiology, it may be either essential 90 to 95% unknown specific cause, multifactorial, environmental factors, genetic factors, fetal factors, humoral mechanisms, insulin resistance, metabolic syndrome, secondary consequence of a specific disease or abnormality leading to sodium retention and or peripheral vasoconstriction. Essential hypertension genetic factors tends to run in families by shared environmental influences, still largely unidentified genetic component. Fetal factors, low birth weight, may be due to fetal adaptation to intrauterine undernutrition with long-term changes in blood vessel structure, are the function of crucial hormonal systems. Essential hypertension, environmental factors, obesity, fat people have higher blood pressures than thin people. Sleep disordered breathing often seen with obesity may be an additional risk factor. Alcohol intake, close relationship between the consumption of alcohol and blood pressure level, but small amounts of alcohol seem to be beneficial. Sodium intake, directly proportional. Some evidence that a high potassium diet can protect against the effects of a high sodium intake. Stress, chronic stress, uncertain, acute pain or stress can raise blood pressure. Humoral mechanisms, autonomic nervous system, renin-angiotensin system, natriuretic peptides and kallikrein system, short-term changes in blood pressure, but no convincing evidence directly involved in the maintenance of hypertension. Insulin resistance, metabolic syndrome, hyperinsulinemia, glucose intolerance, reduced levels of HDL cholesterol, hypertriglyceridemia and central obesity with or without hypertension. Association between diabetes and hypertension has long been recognized. Secondary hypertension, pregnancy, preeclampsia, renal disease, renal vascular disease, parenchymal renal disease, particularly glomerulonephritis, polycystic kidney disease, drugs, oral contraceptives containing estrogens, anabolic steroids, corticosteroids, NSAIDs, carbenoxolone, sympathomimetic agents, coarctation of the aorta. Secondary hypertension, endocrine disease, pheochromocytoma, vascular tumor of the adrenal gland, Cushing's syndrome, excessive cortisol, primary hyperaldosteronism, Conn syndrome, glucocorticoid suppressible hyperaldosteronism, hyperparathyroidism, acromegaly, primary hypothyroidism, thyrotoxicosis, congenital adrenal hyperplasia due to 11 beta hydroxylase or 17 alpha hydroxylase deficiency, Liddle syndrome, 1 beta hydroxysteroid dehydrogenase deficiency. Classification of hypertension by British Hypertension Society. Category: blood pressure optimal less than 120, systolic blood pressure less than 80, diastolic blood pressure Normal blood pressure 120 to 129, systolic blood pressure less than 80 to 85, diastolic blood pressure. High normal 130 to 139, systolic blood pressure 85 to 89, diastolic blood pressure. Hypertension grade 1 mild, systolic blood pressure 140 to 159, diastolic blood pressure 90 to 99. Grade 2 moderate, systolic blood pressure 160 to 179, diastolic blood pressure 100 to 109. Grade 3 severe, systolic blood pressure greater than 180, diastolic blood pressure greater than 110. Isolated systolic hypertension grade 1, systolic blood pressure 140 to 149, diastolic blood pressure less than 90. Grade 2 systolic blood pressure greater than 160 and diastolic blood pressure less than 90. Mechanisms of hypertension: determinants of arterial pressure, cardiac output, stroke volume related to myocardial contractility and to the size of vascular compartment, heart rate, neuronal and hormonal control, peripheral resistance, functional and anatomic changes in small arteries and arterioles. Mechanisms of hypertension: intravascular volume. Sodium is predominantly an extracellular ion, primary determinant of the extracellular fluid volume. When sodium chloride intake exceeds the capacity of the kidney to excrete sodium, vascular volume initially expands and cardiac output increases. Autonomic nervous system: homeostasis via pressure, volume, and chemoreceptor signals. Adrenergic reflexes short-term. Adrenergic function in concert with hormonal and volume-related factors. Long-term regulation: 3 endogenous catecholamines are norepinephrine, epinephrine, and dopamine. Mechanisms of hypertension: renin-angiotensin-aldosterone, vasoconstrictor properties of angiotensin II, sodium retaining properties of aldosterone. Vascular mechanisms: vascular radius, resistance to flow varies inversely with the fourth power of the radius, compliance of resistance arteries, high degree of elasticity, accommodate an increase of volume with relatively little change in pressure. Semi-rigid vascular system: small increment in volume induces a relatively large increment of pressure. Complications of hypertension: atherosclerosis, aneurysms, aortic dissections, hematuria, uremia, proteinemia, chronic kidney disease, pulmonary edema, myocardial infarction, left ventricular hypertrophy, cardiac failure, hemorrhage, infarction, seizures, vascular dementia, stroke, transient ischemic attack, hemorrhages, exudates, AV ripping, papilloedema. Complications: blood vessels, larger arteries greater than 1 mm, internal elastic lamina is thickened, smooth muscle is hypertrophied, and fibrous tissue is deposited. The vessels dilate and become tortuous, and their walls become less compliant. Smaller arteries less than 1 mm, hyaline atherosclerosis, lumen narrows and aneurysms. Atheroma develops coronary and cerebrovascular disease, risk factor: smoking, hyperlipidemia, diabetes. These changes in the vasculature often perpetuate and aggravate hypertension, increasing peripheral vascular resistance, reducing renal blood flow. Central nervous system complications: stroke, most common complication, cerebral hemorrhage or infarction, subarachnoid hemorrhage, hypertensive encephalopathy. Rare conditions: high blood pressure, neurological symptoms, transient disturbances of speech or vision, paresthesia, disorientation, fits and loss of consciousness. Neurological deficit, usually reversible if the hypertension is properly controlled. Complications: retina, optic fatigue, gradation of changes linked to the severity of hypertension, cotton wool exudates associated with retinal ischemia or infarction fade in a few weeks, halt exudates associated with diabetic retinopathy, small white dense deposits of lipids, microaneurysms, dot hemorrhages. In this picture, you can see complications of retina with grades. Complications of heart, coronary artery disease, very high incidence. Reassure load on the heart may lead to left ventricular hypertrophy, forceful apex beat and fourth heart sound. Atrial fibrillation, diastolic dysfunction caused by left ventricular hypertrophy or the effects of coronary artery disease. Left ventricular failure, severe hypertension, absence of coronary artery disease, risk factor, impaired renal function and therefore sodium retention. Complications of kidneys, major risk factor for renal injury and end-stage renal disease. Atherosclerotic hypertension related vascular lesions, pre-glomerular arterioles, resulting in ischemic changes in the glomeruli and post-glomerular structures. This leads to reduced GFR and finally a reduction in sodium and water excretion. Activation of the renin-angiotensin system may cause proteinuria greater than 3 grams per 24 hour, or if untreated, it may cause progressive renal failure. Malignant hypertension, also known as accelerated hypertension, blood pressure rises rapidly, diastolic blood pressure greater than 120 mm of mercury, characterized by accelerated microvascular damage with necrosis in the walls of small arteries and arterioles, fibrinoid necrosis, intravascular thrombosis, diagnosed by rapidly progressive and organ damage, retinopathy, grade 3 or 4, renal dysfunction, especially proteinuria, hypertensive encephalopathy, left ventricular failure may occur, and if this is untreated, death occurs within months. Investigation: all patients, urine lysis for blood, protein and glucose, blood urea, electrolytes and creatinine, blood glucose, serum total and HDL cholesterol, 12-lead ECG, left ventricular hypertrophy, coronary artery disease. Investigation of selected patients: chest X-ray, cardiomegaly, heart failure, coarctation of the aorta, ambulatory BP recording, assess borderline or white coat hypertension, echocardiogram, detect or quantify left ventricular hypertrophy, renal ultrasound to detect possible renal disease, renal angiography, detect or confirm presence of renal artery stenosis, urinary catecholamines, possible pheochromocytoma, urinary cortisol and dexamethasone suppression test, possible Cushing's syndrome, plasma renin activity and aldosterone, possible primary aldosteronism. Management of hypertension: initially, there should be complete assessment with repeated blood pressure measurements for 6 months until it's not severe. Advice and non-pharmacological measures, lifestyle changes should be given prior to the initiation of drug therapy. A target of 140 mm of mercury systolic and 85 mm of mercury diastolic blood pressure is recommended. Diabetes, renal impairment or established CVS disease, 130/80 mm of mercury is recommended. Lifestyle modification in borderline and hypertensive patients: body weight, maintain normal body weight, body mass index 20 to 25 kg per square meter, aerobic exercise, perform greater than 30-minute brisk walk most days of the week. Diet: reduce intake of fat and saturated fat, reduce salt intake less than 100 millimole per day, less than 6 gram sodium chloride or less than 2.4 gram sodium chloride per day. Limit alcohol to less than 3 units per day. Men and less than 2 units per day women. Consume greater than 5 portions of fresh fruit and vegetables per day. Cardiovascular risk reduction. Avoid cigarette smoking and increase oily fish intake. Pharmacological management of hypertension. Decisions to commence specific drug therapy only after a careful period of assessment with lifestyle changes of up to 6 months, unless it's not having end organ damage or other hypertensive complications. Aim, plan and side effect of drug treatment. Carefully explain to the patient. Patient compliance is very essential for efficacy of drugs. Long-term results. The drugs commonly used to treat hypertension are alpha blockers, aldosterone antagonists, angiotensin converting enzyme inhibitors, angiotensin 2 receptor blockers, beta blockers, calcium channel blockers, centrally acting diuretics, renin inhibitors, vasodilators. In this picture you can see drugs with doses: alpha blockers, aldosterone antagonists, angiotensin converting enzyme inhibitors. You can see in this picture angiotensin 2 receptor blockers, beta blockers, calcium channel blockers with doses. You can see centrally acting drugs for hypertension, diuretics, renin inhibitors, vasodilators, and with doses.